So transcaval TAVI is a different approach and a different access approach for the TAVI procedure. So as a background, not all patients are eligible for transfemoral access because of small or diseased iliofemoral arteries. Usually transthoracic, whether it's transaortic or transapical, has more complication than transfemoral access. Transcaval is feasible. It's been described by Greenbaum and Lederman since 2014, and its success and complication of transcaval TAVR during its adoption across multiple medical centers in USA was recently established. So usually the conventional access for TAVI are transfemoral, which is around more than 90% of your cases. Usually if this doesn't work, you try to go subclavian or transaxillary. This is my second option. And then you can either go transaortic, transapical, or transcarotid. But recently, transcaval has came as probably the third option before a surgical approach. So the concept of transcaval TAVR is to take the vein, which has much larger diameter than the artery, try to bypass the femoral arteries or the iliac arteries that are diseased, create a connection between your IVC and your aorta, do your TAVI in a conventional way, and then on the way out, close the track you created. And the physiology behind it, why it works, is because your retroperitoneal space has a higher pressure. So if you look here on the aorta, usually imagine you have a pressure of 80, the vein pressure is 5, and usually the retroperitoneal space is 10 to 15 millimeter higher than your venous pressure. So if you create a hole between the aorta and the IVC, you're not going to bleed to death. You're going just to create a fistula. The blood is going to go from the aorta into the IVC without any major hemodynamic compromise. So, and another fundamental concept while doing these cases, you never want the catheter in between the IVC and the aorta, because you took away your fistula, and now all the aortic blood is going to go into the retroperitoneal space, and patient is going to die and bleed to death. So this is very important. You never want your catheter sitting like in panel A, where you're occluding your vein. So there was a study of 100 patients that got published end of last year, and it was an IDE trial done by the NIH, supported by the FDA, and it was done in people who are inoperable and extreme risk and with rigorous CT planning. And the STS score in these people were high, around 10 plus or minus 6.3, so high risk or inoperable. So surprisingly, the transcaval success was 99 out of 100, and one failure because they have inability to cross. And from a device success standpoint, 98 out of 100 had good closure, and the one was one failure to cross, and the other was failure during the plug closure, and they had to put a cover stent at the aorta. Okay, and around 35% ended up having transfusion during this procedure, and this is one of the main initial problems when they started with transcaval, but this gone down tremendously. And if you can look, these people only stayed 4 days in the hospital. And if you look at the transcaval compared to transapical or transaortic in the PARTNER 2 trial, you had a higher STS score, but you have way lower life-threatening or disabling bleeding compared to transaortic or transapical, who have around 20% in the VAR criteria. And if you compared the experienced site versus the non-experienced site, the VARC complication were low, around 17%. So I'm going to go step by step the case that we've done earlier mid-year at UBMC. So we had this patient who had very small and diseased iliac and femur on the left and on the radial, on the right side. You're talking 3 to 4 millimeters, so this is impossible for TAVI. And then if you look at the subclavian or the transaxillary, my second option, you also have 3 millimeter that is not amenable to percutaneous TAVI. And on the right panel, you can see that you have a porcinal aorta, so you cannot go direct transaortic. And if you look at the planning, you have a severely calcified valve, severely calcified ST junction, severely calcified aorta. You have a low left main and a very small ST junction. And usually when you want to decide to do transcaval, you have to do a very good planning. So if you look on the right portion on the top, you can see we mark with the yellow marker which rib you want to cross. And if you look at the bottom left, I pointed with the yellow line, a calcium-free zone. You don't want to puncture through calcium because your wire is not going to go through. So you choose a position where you don't have calcium and you have proximity between your IVC and your aorta. And here in this patient, it was between L2 and L3. The issue with this patient that you had the left renal below the target and the right renal above the target. So if you end up with a complication and you have to put a cover stent, you're going to have to occlude one of your renals. And this is the 3D reconstruction where you're seeing the IVC and the aorta. And in the yellow, you can see where I was going to puncture. And this is a calcium-free zone in the aorta and where the IVC is close. Okay, so your initial shot, you have to take bilateral injection between your IVC and your aorta. You can tell how diseased the aorta, how small. This is actually it wasn't an easy case to do as because the aorta is extremely small. But usually you inject both to see where you want to puncture. So then after you take your angiogram, you have to prepare your system. So usually the way it works, you need a 014 wire, which is usually a Confianza wire that you amputate the tip, that you put within a wire converter, either a fine cross or a piggyback wire, and that you introduce all this in a 035 microcatheter, in this instance, the Navicross. Then you take the back end of the wire and you attach it to an electrosurgery pencil and you clamp it. And this is where you're going to deliver your energy. And usually you put the energy RF ablation that you use for transeptal puncture in a cutting mode, around 50 watts. And this is how it looks on in the cath lab. You position your delivery catheter in the IVC. You have the wire tip touching the IVC, and you have your microcatheter behind it. And then you go into between RAO and lateral view to make sure you're good in an anterior-posterior position, so you can target your wire into the snare that you positioned into the aorta. So you can never do it in one plane. You have to make sure you have your LAO position too. And here you're going to see my wire about to cross. I'm advancing my microcatheter. The wire is touching the IVC. And then I'm going to apply the energy here, and you're going to see the wire crossing into the aorta. So now I have my wire around the snare. The next step that I want to do, I want to snare the wire. And here you can see I snared my wire and I advanced it all the way to the ascending aorta. And on the right side, now I have an 014 wire in the aorta, but I still have to advance my fine cross. And you can see my fine cross going all the way into aorta. The next step, now I have my third catheter, which is the 035 wire. You can see it, I'm trying to puncture the aorta with it, and I'm getting a resistance. So what I do, I'm advancing my sheet, make sure I have good support, and you're going to see the Navicross 035 microcatheter crossing into the aorta. And after crossing, I advance my Lunderquist wire. The Lunderquist wire is a very stiff wire, similar to the M+ Extra Stiff, but stiffer in order to have a lot of support. After advancing my wire, you can see on the right side, I have my E-sheet from Edwards crossing all the way into the aorta in a very smooth fashion. There's no resistance. It's very easy to puncture the IVC and the aorta. You barely have any problem doing that. And then you do your TAVI in a regular fashion. This case was not easy because there was a lot of calcification, ST junction, low left main, and a small valve. So we deployed our valve, had good result with some trivial paravalvular leak. And this is the easy part of the procedure. Then the hardest part of the procedure is to close the track. So you did your puncture, now you have a fistula, you have to deal with it to make sure you want to close it. So usually when you have a lot of distance between the IVC and the aorta, and you're putting a large sheet like the Edwards sheet, you have to close it with a 10-8 AD01 device. So here, step by step, please look at the screen. I have my sheet that I'm withdrawing into the IVC. I have an Agilis sheet and the head and the left atrial side of the AD01 that I'm positioning. I'm curving my Agilis so I'm coaxial to the aortic wall, and then all of a sudden I'm going to pull back. Now I have contact between the AD01 and the aorta. I'm putting my pigtail, I'm doing an injection, I have a good apposition, and now I'm going to retract my agilis to deploy the other side of the disc, and you're going to see it here. And then you advance and form the other side, okay? And look at the right side here, I took an injection. There's a good seal, there's still a fistula, which usually is not a problem, and they're hemodynamically stable. During the procedure, the blood pressure did not drop at all. And here I released my plug. I tamponaded with a Taishak balloon, 12 millimeter, just for 2 minutes, so I have the fistula tract closing. And this was my final angiogram. I'm not sure if this is gonna play. Okay, that's fine. So usually the type of closure you get, you have what we call a type 0. You don't have any communication between the aorta and the IVC. Type 1 is the one you get, which is the remaining fistula between the aorta and the vein that usually closes within hours. You have the type 2, which is the most common pattern, and it has a cruciform extra-aortic contrast that causes no hemodynamic challenge. And the type 3 are the one that need an endograft by the end of the case. This was the CT post-discharge with complete closure with the device sitting between the aorta and the IVC. And this is a summary of the transcaval. Bilateral injection, you cross in AP and lateral, you snare your wire, advance your sheet, deploy your valve, and you close. And this has been applied more than 200 patients to date. This was the first case done in the Middle East and Asia, and hopefully we're going to do more of these. Thank you.